Hello everyone, and thank you for the opportunity to present to you today on VAHI's approach to supporting safety and quality improvement. The way in which we hope to take you on the VAHI journey is by starting with the obvious of who we are and how we've come to be, what we hope to accomplish and how, and some of our key achievements, those in development, but also a little bit about what's on the horizon. As some of you may know, VAHI was established in July 2017 as a recommendation of the Targeting Zero Review. Our mission is about providing trusted information to inform better decision that supports improvement in health and well-being of Victorians. Essentially, this translates into meaningful and actionable information that meets the needs of our stakeholders. And aspects of health and well-being capture health service-related performance outcomes, but also broadly population health status and determinants of health. Since inception, our immediate priority was to focus on setting the foundation for delivering on expectations outlined in the Targeting Zero. Further on, we started to mobilize effort towards increasing our impact in terms of insight and capability, and more recently started to explore opportunities for increasing the breadth of information across care settings and sectors. In practice, we deliver our strategy through a number of initiatives aligned to our 4 work streams. For example, in terms of our foundational priorities, we have commenced the digital transformation of core reporting products and implemented a data and analytic request hub. In terms of enriching our products and services, we provide a range of regular and ad hoc reports on quality and safety and health system performance. We have primary responsibility for a range of programs, including the Victorian Health Incident Management System, VIMS, the Victorian Health Experience Survey, and Victoria's Population Health Survey. Looking further afield, we developed an analytic strategy that considers our people, infrastructure, and advanced methods of analysis, which we use in part today, but which will become a more routine feature of our work in the future. And last but not least, we have started to expand our scope beyond the routine administrative data set by incorporating richer sources of data such as clinical registries. And we are starting to use insight from a range of linked data sets. So in a nutshell, our primary focus is using data for quality and safety improvement. And we do that through close collaboration with our stakeholders to identify their needs and expectations, the provision of a number of information products and programs, and closing the loop on the actionability by supporting the interpretation of that information through a range of data literacy programs. In terms of internal capability, we have made a number of improvements in the range and skills of experience so that we can better support our functions. In particular, we look to grow our advanced analytic expertise and infrastructure to meet our needs for the future. We measure our performance and progress in terms of outputs, impacts, and benefits. And whilst we know there is scope to improve, we are motivated by our achievements and your feedback so far, recognizing we are still a very young agency, but encouraged by the increased appreciation of data and opportunities generated through the pandemic. We're very keen to leverage on many of those. In terms of our core programs, we have achieved a lot in terms of the rollout of our new incident management system, VIM Central, which my colleague Paula will speak to shortly. Suffice to say, that paves the way for incidents reporting to be added to the suite of products supporting quality and safety improvement. We've also increased the utility of CQRs by confirming arrangements across a number of registries, but also commencing reporting of measures arising from CQRs as part of our routine reports. We commenced a major reform of the patient experience program in Victoria, and we modernised the way in which health service performance data is provided to the public. We created a data and analytic request hub, which enables a single point of intake and coordination, but also will assist in the future automation opportunities for those more regular requests. We enhanced the reporting of population health survey, which informs policy and planning across local and state government, and published separate insight reports into findings related to specific population groups such as Aboriginal health, family safety, LGBTIQ, and palliative care. For those less familiar with the programs, I've included links at the bottom of the slide, but I'm also conscious that sometimes it is more effective to have someone familiar to walk you through those, and for that reason, please don't hesitate to reach out. Each of those pages has details as to where to and who to contact. In terms of our core reporting products, as some of you know, VAHI has developed Victoria's first private hospital safety and quality report, which compares results between peer organisations and over time. Through this product, we've opened the door to a positive collaboration with our private hospital, showcasing the excellent contribution they make to the Victoria's quality and safety improvement journey and where opportunities may exist. We very much hope that we can build on that collaboration to evolve the data transparency agenda, not just between private hospitals, but also between privates and publics, to enable that statewide sector view of quality and safety, which is very important from a holistic perspective, but also aligns to the expectations outlined by the Targeting Zero review. In relation to the monitor, we have consolidated all the performance monitoring measures into the one report and added time series visualizations with control limits to better support interpretation of trends over time and to point to opportunities for improvement before they become outliers. We have also added new shadow indicators in the PRISM reports focusing on surgery, in particular emergency surgery. We explore the opportunity of creating a series of reports specific for clinicians. The Mental Health Inspire product is a good example and a more established one. As some of you may remember, we developed a generic statewide version and implemented it over a few quarters. However, feedback received indicated that it was insufficiently specific to provide specialties with the breadth of information they needed. And therefore, we have embarked on a more targeted development of future Inspire products in consultation with our colleagues in Safer Care Victoria, so that we can better align the content to the needs of the clinical audience. For example, just before COVID, we were collaborating with the Palliative Care Insight Group on a new Inspire report specific to end-of-life care. At the time, we also recognized that other areas were of a priority, for example, pediatric and emergency care. And although they were flagged at the time, pandemic has obviously prohibited us from progressing. As the centers of excellence are being re-established and the data and information is reconfirmed, we will no doubt continue on this journey to provide more targeted information to clinicians on quality and safety. Another significant component of our work is the quality and safety reported to boards. VAHI has created a first report of its kind, which is now aligned to Safer Care Victoria's clinical governance framework. This framework is underpinned by three pillars of clinical governance: safety, effectiveness, and patient-centered care. The report includes a sample of measures associated to these domains and subcategories, but also highlights where additional information is yet to be collected at the statewide level and where local information may be more easily available to inform boards' clinical governance remit. For example, complaints and workforce-related measures. In recent times, we've expanded the range of measures to include some derived from CQRs, and with the most recent edition, we've also introduced a new all-HAC measure, that is hospital-acquired complication measure, based on the last specification by the Commission. For the future, it is likely that we will see more information relating to clinical incidents and potentially low-value care, or as known in Victorian policy context as best care. Equity is another relevant area that boards identified as important to their mandate, and as such we will look to see what information could be provided, in particular around the more vulnerable cohorts, but also between public-private patients. The report is also providing boards with detail about how to interpret the information and what questions to ask. In relation to interpretation, we've met with many board members before COVID during a joint Safer Care VAHI Clinical Governance Foundation program. And subsequently, we developed a series of short videos on how to make sense of commonly used graphs that new and existing board members may find useful. A link to those is provided at the bottom of these slides for those interested to view them. As I indicated earlier, there is a list of new indicators which have now been implemented as part of the PRISM report. They capture elective surgery clearance time and emergency surgery measures and are still considered shadow measures for the purpose of the performance monitoring framework. Business rules outlining how these measures have been calculated were released to health services at the time of the report distribution, but are also available upon request, so please email us should you wish to see a copy of those. And going back in time a little, whilst we are not progressing a future edition of the statewide Inspire product, the last issue did cover a longer-term perspective of trends for some core indicators going back almost 10 years. I know that some of these slides were shared with you, or with the sector rather, at the last annual forum, but some of you may not have seen them. So I am hoping that you see value in them. For example, the improvement in infection rates, in particular the decline in CLAPSI, which has been seen across the state, is commendable. Also, the significant improvement in the percentage of healthcare worker immunization for influenza, for example. That is also a significant improvement. There were also a number of results that remained stable, such as the overall safety culture question captured in the Victorian People Matter survey, which has been steady since 2014. I understand that the latest People Matter survey results have just been released, but may not be comparable to prior years due to the voluntary nature uptake this year and the shorter survey methodology applied. There are also some measures that indicate a higher level of variation across the sector, for example, readmission post-hip replacement. No significant change, however, the variation in results continues to be evident, providing opportunities for further improvement. As some of you would know, hip replacement readmission measures are now included as part of the statement of priority and continue to be reported this year in the monitor report. However, we have developed new methodology for calculating and reporting on a range of readmission measures, which my colleague Adina Hamilton will speak to later on. In terms of where we need to go. The digital transformation journey has already begun. Our goal is to transition as much as possible into interactive, dynamic reporting, starting with the Victorian Health Performance portal and moving into more content and lower level of granularity through the authorized VAHI portal environment. For those that have already been granted access by their CEO and have activated their account, you should be able to explore the current measures relating to COVID-19, including emergency department presentation data. These measures are sourced from the Victorian Emergency Minimum Dataset and enable you a focus over time and searchable by patient, postcode and hospital. Other recent developments relate to the introduction of download capacity for PDF reports. CEOs and board chairs have started to receive and will continue to receive notification emails about the availability of these reports from the portal, and through that the establishment of a searchable library of reports so that anyone who has authorized access can go back in time and search for those relevant reports. Not far from now, authorized users will also be provided access to Best Care Interactive Digital Report, which will enable comparison of results across the sector, but also to showcase where some of those improvement areas may lie. I know that Professor Waters will provide much more detail about this development in the upcoming session. That is all from me. Thank you for your time and look